Welcome to this Step 2 clinical knowledge review on movement disorders test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for movement disorders and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the neurology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for movement disorders on your board exam. Second, we will apply test-taking strategies specifically for tremor classification, chorea, and restless legs questions. Third, we will master the most likely diagnosis question format for Parkinson's disease, essential tremor, Huntington disease, and restless legs syndrome. Before diving in, make sure you have reviewed first aid, your question bank, and pathoma for the foundational content. This video is all about applying that knowledge strategically on exam day. Let us start with one of the most important distinctions the boards will test you on, the tremor classification split. On the left side, we have resting tremor buzzwords. When you see a pill-rolling tremor at rest that improves with intentional movement, combined with cogwheel rigidity and bradykinesia, this is the classic triad for Parkinson's disease. The boards test this pattern frequently, so lock it in. On the right side, we have action tremor buzzwords. When you see a bilateral postural and kinetic tremor that worsens with action, improves with alcohol, and has a positive family history, this points to essential tremor. The boards love comparing these two tremor types together, so your job is to identify whether the tremor is at rest or during action. That single distinction will guide you to the right answer. Now let us talk about recognizing Parkinson's disease features, which is our second major strategy. On the motor side, the classic presentation includes unilateral resting tremor, cogwheel rigidity, bradykinesia, and a shuffling gait with reduced arm swing. Asymmetric onset is a key distinguishing feature. When a question describes a slow, shuffling gait with masked faces, always think Parkinson's disease. On the non-motor side, depression, anosmia, rapid eye movement sleep behavior disorder, and constipation can precede motor symptoms by years. Dementia may develop in later stages. The boards love asking about non-motor features as early clues to the diagnosis before the classic motor triad appears. Keep these non-motor features in your back pocket for tricky questions. Let us go through some high-yield stem recognition patterns. For a Parkinson's disease stem, look for an elderly patient with asymmetric resting tremor, bradykinesia, and cogwheel rigidity. They will describe a shuffling gait and masked faces. The diagnosis is clinical and treatment begins with carbidopa-levodopa. For an essential tremor stem, look for bilateral postural and kinetic tremor affecting the hands, a positive family history, and improvement with alcohol. There will be no rigidity and no bradykinesia. First-line treatment is Propranolol or Primidone. For a Huntington disease stem, look for a middle-aged patient with progressive chorea, psychiatric symptoms, and a family history of a similar condition with autosomal dominant inheritance. Confirm with genetic testing for trinucleotide repeat expansion on chromosome 4. Here is our first practice question. A 68-year-old man presents with a 6-month history of right-hand tremor that is most noticeable when he is sitting in the waiting room. On exam, he has a pill-rolling resting tremor of the right hand, cogwheel rigidity of the right upper extremity, and difficulty initiating movement. His gait is slow and shuffling. What is the most likely diagnosis? Take a moment and think about what patterns you recognize here. Is it answer A, essential tremor, answer B, Parkinson's disease, answer C, Huntington disease, or answer D, physiologic tremor? Let us walk through this answer together. Step 1, spot the pattern. We have an elderly patient with a resting tremor, cogwheel rigidity, bradykinesia, and a shuffling gait. This is the classic Parkinson's disease triad. The resting tremor with pill-rolling quality is the key differentiator from essential tremor. Step 2, apply the rule. Remember, Parkinson's disease presents with asymmetric motor symptoms. Essential tremor is bilateral and postural. A resting tremor equals Parkinson's disease on the boards until proven otherwise. Step 3, eliminate wrong answers. Answer A, essential tremor, causes bilateral action tremor, not unilateral resting tremor. Answer C, Huntington disease, causes chorea, not pill-rolling tremor. Answer D, physiologic tremor, is fine and postural, not resting. The correct answer is B, Parkinson's disease. Here is our second practice question. A 55-year-old woman presents with a several-year history of bilateral hand tremor that worsens when she reaches for objects. She reports that her father and sister have a similar tremor. The tremor improves after she drinks a glass of wine. Neurologic exam shows no rigidity and no bradykinesia. What is the most likely diagnosis? Think about what key features stand out here. Is it answer A, Parkinson disease, answer B, essential tremor, answer C, cerebellar tremor, or answer D, hypothyroidism? Let us break this one down. Read the question carefully. The question describes classic essential tremor features: bilateral, postural, action tremor with a family history and alcohol responsiveness. There is no rigidity and no bradykinesia, which rules out Parkinson disease. A cerebellar tremor would show ataxia and dysmetria, which are not mentioned here. Now, why does essential tremor win? Essential tremor is the most common movement disorder. The combination of bilateral action tremor, family history, and alcohol responsiveness is the classic board presentation. Hypothyroidism would show additional systemic signs like weight loss, tachycardia, and heat intolerance. The correct answer is B, essential tremor. Now let us cover Huntington disease for the boards. On the genetics and diagnosis side, Huntington disease is autosomal dominant with a trinucleotide repeat expansion of cytosine adenine guanine on chromosome 4. Anticipation means that successive generations have earlier onset and more severe disease. Genetic testing is confirmatory. The boards often describe a parent who died young with similar symptoms, which is your clue for autosomal dominant inheritance. On the clinical presentation and management side, chorea, behavioral and psychiatric changes, and progressive dementia form the classic triad. Caudate atrophy on brain imaging is a high-yield finding. There is no cure. Tetrabenazine is used for chorea symptom management. The boards love asking about the combination of chorea with psychiatric symptoms and a strong family history. Here is our third practice question. A 35-year-old man presents with involuntary jerky movements of his arms and legs that have progressively worsened over the past year. His wife reports personality changes, including irritability and impulsive behavior. His father died at age 45 with a similar movement disorder. What is the most appropriate next step in diagnosis? Think about what combination of features is being presented here. Is it answer A, brain magnetic resonance imaging, answer B, genetic testing for trinucleotide repeat expansion, answer C, dopamine transporter scan, or answer D, serum ceruloplasmin level? Let us walk through this answer. First, spot the classic pattern. Chorea plus psychiatric symptoms plus autosomal dominant family history is the classic Huntington disease triad. When the boards give you a parent who died young with a similar movement disorder, they are hinting at autosomal dominant inheritance with anticipation. Now, know the key distinction. Brain imaging may show caudate atrophy but is not confirmatory. A dopamine transporter scan is for Parkinson disease, not chorea. Serum ceruloplasmin is for Wilson disease, which presents in younger patients with additional liver findings. The correct answer is B, genetic testing for trinucleotide repeat expansion. Let us finish with a key test-taking pearl on restless legs syndrome. For classic stem recognition, the classic stem describes an uncomfortable urge to move the legs that worsens at rest and in the evening, and improves with movement. Always check serum ferritin and iron studies because iron deficiency is the most common reversible cause. The boards will often test this connection between restless legs and low iron. Why does this matter on the exam? First-line treatment for confirmed iron deficiency is iron supplementation. If iron levels are normal, dopamine agonists such as Pramipexole or Propranolol are first-line pharmacotherapy. The boards may also associate restless legs with pregnancy, kidney disease, and peripheral neuropathy. These associations are high-yield and commonly tested. That wraps up our movement disorders, test-taking strategies review. For study resources, review the neurology chapters in First Aid and your question bank. Focus on movement disorder classification, the tremor differential, Huntington disease genetics, and restless legs syndrome workup. To connect with us, visit www.roadmap2residency.com for expert tutors and residency advisors. If you found this video helpful, please like and subscribe for more board review content. Good luck on your exam.